So welcome again, continuing with the same emergency psychiatry series. Now we are going to learn about delirium and organic mental disorders. So I am Dr. Swaleha Mujawar, assistant professor, and I'll be teaching you about this topic. So what we are going to cover, what is organic psychiatry, what is delirium. So in delirium, we are going to learn about introduction, clinical features, diagnosis and management. So as psychiatrists we always say कि organic case है organic case है तो organic case में आता क्या है ठीक है so classification of organic mental disorders can be acute organic mental disorder, chronic, then organic amnestic and other organic. इसमें से भी the first two acute and chronic are important because these are the cases which you're commonly going to see. So if the organicity is acute, the patient is mostly delirium. If the patient presents with a chronic organic mental disorder, that comes under dementia. So as emergency psychiatry doctors, you will be seeing mostly acute cases. So that is why we are going to learn about delirium today. Delirium, you're going to see this everywhere if the patient is post-op, a medical patient, neurological patient. This is something which you're going to definitely see. So whenever a patient comes to you and you're trying to assess the patient, first understand what is delirium. So in introduction, I would like to say that delirium is a transient global disorder of cognition. Basically, cognition is getting impaired. It is a medical emergency and it is derived from the Latin word which means off the track. Why is it important? Why is it an emergency? Because it leads to increased mortality. We need a lot of nursing care for this. And in future, it leads to failed rehab, it leads to delayed discharge. So treating this is very, very important. And a lot of times it goes unrecognized also. Many cases are undiagnosed. Approximately 40 patients of elderly with delirium are sent home. And sometimes it is misdiagnosed as depression. Again, around 40 cases are misdiagnosed. So then they are not treated well. Looking at the epidemiology, 20% of patients of general ward have delirium, 30 patients in elderly because it is more commonly in elderly, and we don't know about the community incidence, but maybe after 85 years of age the incidence increases to 10%. If the patient is more than 65 with dementia, again the incidence increases. Again in special populations, so long-term residents, surgical patients, cardiac surgical patients, very, very high chances. Again, ortho ward, so patients with hip fracture, more than half patients with hip fracture develop delirium. Again, if the patient has more than 65 years of age and admitted in the ICU, the chances are 70%. This is very, very high. So this is also called as ICU psychosis. When delirium occurs in the ICU, the diagnosis made as ICU psychosis. Palliative advanced cancer patients, 88% chance. So very, very high chances of this occurring. So as psychiatrists, we follow diagnostic and statistical manual. So what is the DSM definition of delirium? One, we need a disturbances in consciousness. So patient is either drowsy or going in and out of sleep. So there is disturbances of consciousness with reduced ability to sustain or shift attention. Then there is a change in cognition or development of a perceptual disturbance not explained by any other condition. And there is a disturbance which develops over a very short period of time. That is why this comes in acute, क्योंकि period of symptoms or development of symptoms is very short, probably a few hours or a few days, not more than that. And this fluctuates, very, very important. So in between the patient might be normal, and in between patient might go into delirium again. So delirium is a problem in consciousness and cognition which occurs acutely and it fluctuates. So these are the core features of delirium. Other clinical features that we've seen, it is acute in onset, develops over hours or days. Onset might be abrupt also. A prodromal phase might be present. So before the development of overt symptoms, some gradual onset symptoms might be seen in the form of fatigue or daytime somnolence, decreased concentration, irritability, restlessness, anxiety, mild cognitive impairment. So these might be present in the prodromal phase in some patients. Fluctuation is very, very important. And this is a very unpredictable fluctuation. Patient can go in and out of delirium without any stimulus, or even during your interview patient might become oriented to time, place and person and then become disoriented again. It is intermittent. Mostly it worsens in the night. This is called as sundowning. So when the sun goes down, the symptoms get worsened. There are periods of lucidity. So in between when the patient is normal, these are called as periods of lucidity. Psychomotor disturbance can be present. Patient can be restless, agitated, or patient can be lethargic or inactive. So according to this, patient can have hyperactive delirium or hypoactive delirium. So these are the two types of delirium that the patient can have. So disturbances in consciousness, patient can be hyper alert, that is overstimulated, or can have normal alertness, can be lethargic, can be comatose also. Inattention is basically a reduced ability to focus, sustain or shift attention. So you will see this in the form of easy distractibility. So when you're talking to the patient, the external stimuli might interfere. तो कहीं दूर कुछ तो आवाज होता है तो patient might get distracted and shift their attention to that voice. It may account for all cognitive deficits also, because attention is very, very important. There is a disruption in sleep-wake cycle also. So patient might have fragmented or disturbed sleep. Patient can have vivid dreams, nightmares, and this they might have difficulty distinguishing from real perception. So they feel whatever dreams that they are having is actually true. Patient might be somnolent इन द डे टाइम, और ही में फील कि ऐसा लग रहा है सपने जैसा हो रहा है, ड्रीम लाइक हो रहा है. इमोशनल डिस्टर्बेंसेस, फियर, एंजाइटी, डिप्रेशन कैन अकर. There are some disturbances of thought also. So abnormalities in the form and content of thinking. So their thinking is not organized. It can be bizarre or illogical also. So patient might be just talking irrelevantly. Uh, Psychotic content can also be seen. So delusion of persecution are very, very common. Judgment and insight is poor. In fact, when I was working in Mumbai, there was a patient in the ICU who actually killed the other patient. So it had become like a very big incident. Patient was in delirium, a patient was not treating, and then he took a saline ka rod and we lost another patient just due to delirium. So this can actually escalate very quickly. So you have to be very careful. There can be disorders in language. So language can be slow and slurred. Patient can have word finding difficulty, difficulty in writing. There can be disorders of memory and orientation also. So there is poor registration, recent remote memory. So what they had for lunch or dinner. Yeah, some people will come and meet them, but they will not remember. Confabulation can occur, and disorientation to time, place and person. So this is very, very commonly seen. Perceptual disturbances. So patient can have distortion like macropsia and micropsia. Macropsia means everything will appear big to them. Micropsia means everything will appear small to them. Derealization, depersonalization. कि जो भी हो रहा है वो रियल नहीं है. Illusions, so misinterpretation of external stimulus, like there will be a wire kept but patient will see a snake in the form of wire. Hallucinations usually are visual, often occur during the night when they are not able to see properly. They can be simple, they can be complex. Auditory hallucinations, they might hear simple sound, music, voices. Tactile hallucinations, even though they are very uncommon, but they can also occur in delirium. Now, does delirium present similarly in all patients? Like we have seen a long list of signs and symptoms, but it is not necessary that all of them will be present in all patients. There will be a permutation and combination, and according to these, we can classify them into three clinical variants: hyperactive, hypoactive, and mixed. So in hyperactive, patient is restless, agitated. Autonomic arousal can also be there. In hypoactive, patient is lethargic, drowsy, they might be confused. And this hypoactive type of delirium is actually misdiagnosed or underdetected, because hyperactive, everybody is vigilant towards the patient also, but if the patient is hypoactive, sometimes even we as doctors do not notice it. Mixed means patient has hyperactive, hypoactive, both symptoms. Now we have some screening tools. So as part of the assessment, we can use MMSE, which we use for mostly for dementia, but we can use it in delirium patients also. We have a scale called as CAM, Confusion Assessment Method. So you can use this scale. MOCA is again a scale, Montreal Cognitive Assessment Scale. So these are a few scales that you can apply. Investigations, long list. Anything under the sun can cause delirium. So we have CBC electrolytes, kidney function test, calcium, liver function test. So according to the patient's symptoms, you can send the investigations. And always, always remember it is a medical emergency. So very quickly just do a physical examination. More importantly, a neurological examination. Check for hydration and nutritional status. If possible, correct it as soon as possible. Evidence of sepsis, if it is there, you need to treat it immediately. If alcohol abuse, alcohol withdrawal is there, again, treating it as soon as possible will save the patient's life. So what are the risk factors which put the patient at risk for delirium? Dementia is one of the most consistent risk factor. So if the patient has underlying dementia, then the chances are 25 to 50%, and it increases the risk by 2 to 3 times. So delirium on dementia can occur, and in elderly people, other risk factors are also there. So they are physically very fragile, they have multiple medical problems, they are very prone to infections also, more commonly chest and urine infection. They are also on a lot of medication, and polypharmacy puts the patient at risk for delirium. So a lot of times just stopping all the medication is the treatment for delirium. Sensory impairment, metabolic disturbance, long bone fractures, general anesthesia, these are all risk factors for delirium. Now, what are the causes? So, severe physical mental illnesses which interfere with the normal metabolism of function of the brain can be a cause. So we have some mnemonics if you want to learn the causes. So we have infections, withdrawal, acute metabolic acidosis, renal failure, trauma, any CNS pathology ranging from epilepsy to hemorrhage, hypoxia, B12 deficiency, thiamine deficiency, a lot of endocrine causes, mostly occurring from thyroid, parathyroid, sometimes glucose fluctuations can also occur, vascular causes like stroke, MI, heart failure, toxins, like digitalis toxicity, antidepressant toxicity, anticholinergic steroids, recreational drugs, heavy metal poisoning. So these are the long list of causes for delirium. Pathophysiology is not very well understood, but we feel that it is mainly because of reversible impairment of the cerebral oxidative metabolism. So basically brain का ऑक्सीजन सप्लाई ठीक से हो नहीं पा रहा है, मेटाबॉलिज्म ठीक से हो नहीं पा रहा है, प्लस some neurotransmitter abnormalities also. The neurotransmitter most commonly involved, I'm sure ये नीट में भी तुम लोगों ने पढ़ा होगा वैसे, but acetylcholine. So if you want one neurotransmitter for delirium, that is acetylcholine. And that is why anticholinergic drugs cause delirium very commonly. They cause acute confusional state, and Alzheimer's may be cholinergic abnormality hoti hai, so they are also more prone for delirium. Excess dopamine can also cause delirium. Excess serotonin can also cause delirium. There are some inflammatory mechanism also. So interleukin 1 is increased, stress reaction, sleep deprivation, disruption in the blood-brain barrier. These are also possible mechanisms. So now coming to the treatment. What can you do? We have non-pharmacological approaches and pharmacological approaches. And remember, non-pharmacological approaches are also equally important because we keep focusing on the medicines. But remember, assessing safety is very, very important. If you feel there is a harm to self or other, restrain the patient. Physical restraints can be applied. Make sure there is adequate oxygenation, electrolyte balance, adequate hydration. Correct the sensory deficits. Manage pain. Sometimes pain management actually is a treatment for delirium. Make sure there is a normal sleep pattern. Optimize communication. So have a very calm and supportive approach. Avoid confrontation. We use a lot of reorientation strategies also. So you tell the relatives कि बार बार उनको time बताओ, बार बार उनको calendars बताओ कि आज ये दिन है, आज Wednesday है, अभी 2 बज रहे हैं दिन के. This also helps a lot in this. Staff consistency भी important है. Involve friends and family. Promote some meaningful activities because ICU वगैरह में they have nothing to do. Sometimes just giving them activities also helps. Provide education about the delirium to the relatives. If the patient is very old, try to mobilize them, give them a proper routine, encourage self-care, optimize the environment. तो बहुत ज़्यादा sensory stimulated environment नहीं होना चाहिए. हम बोलते हैं कि dark room जो थोड़ा calm हो, जहाँ पे minimum noise हो, लाइटिंग भी अच्छी होनी चाहिए और it reduces misinterpretation, promotes sleep, provide familiar objects, familiar people, and evaluate the response to management. So pharmacological management, always remember psychotropic medication should be reserved for patient जो बहुत ज़्यादा distress में है due to agitation or psychotic symptoms. In the absence of psychotic symptoms causing stress, treatment of hypoactive delirium with psychotropic medication is not recommended. तो पेशेंट को अगर जरूरत नहीं है तो एंटीसाइकोटिक्स नहीं देना है. Psychotropic medications are not indicated for wandering also. We want to keep the patient at minimum medications at the lowest dose. That is our main aim. So what are the types of medications that we commonly use? Antipsychotics are more commonly used. Typical antipsychotics like haloperidol. Haloperidol injectable form में भी आता है तो वो अच्छा है. Atypical में we have olanzapine. Olanzapine भी injectable form में आता है. So these are the two commonly used drugs. Benzodiazepines, again lorazepam, diazepam we use. Cholinesterase inhibitors and other medications. So haloperidol has the advantage that it is less anticholinergic, it is less sedating. And we have a lot of formulations available, like injectable में भी आता है, oral में आता है, syrup आता है. So whatever you want to do, just remember start at very very low doses. So haloperidol is given at 0.25 to 0.5 mg either once or twice a day. But whenever you're giving haloperidol, always remember there is a risk for QTC prolongation. तो ventricular arrhythmias होना बहुत risky होता है, तो get a baseline ECG done. That is always helpful. Extrapyramidal side effects can occur like acute dystonia, Parkinsonism, akathisia. Neuroleptic malignant syndrome can also occur. Orthostatic hypotension हो गया तो patient can fall bathroom वगैरह में, they can have injuries. Over sedation should also be kept in mind. Atypical antipsychotics mein, like I've told you, olanzapine is there. Sometimes we use risperidone also, we use quetiapine also. So these are all atypical antipsychotics. Atypical antipsychotics का फायदा ये है कि एक्स्ट्रा पिरामिडल साइड इफेक्ट्स नहीं होते, ठीक है. तो कुल बट यही याद रखो, ओलांजापिन हैज एंटीकोलिनर्जिक प्रॉपर्टीज, तो वो थोड़ा प्रॉब्लम हो सकता है. बाकी प्रॉब्लम्स है मेटाबॉलिक सिंड्रोम, तो ग्लूकोज डिसरेगुलेशन, इंक्रीज इन कोलेस्ट्रॉल, ये सब हो सकता है. All atypical antipsychotics have increased risk of stroke or mortality in dementia patients. So keep this in mind. Keeping this in mind, हम haloperidol ही use करते हैं. But if you want to use atypical antipsychotics, you can use risperidone 0.25 mg OD or BD, olanzapine 1.25 to 2.5 mg per day, quetiapine also 12.5 to 50. So these are very very low doses actually, and they are preferred in patients with Parkinson's disease or Lewy body dementia. Other treatments, we have benzodiazepines, especially if there is alcohol withdrawal, तो फिर we prefer benzodiazepines. But remember, benzodiazepines, they themselves exacerbate delirium. So if you can avoid them, avoid them. But if the patient has alcohol withdrawal, then it is a treatment of choice. We can give cholinesterase inhibitors also. We can use other drugs like trazodone, which is an antidepressant, but we very rarely use them. It has a poor prognosis, especially in elderly. So always taking a high risk consent, explaining to the relatives also that there will be a lot of functional disability, the hospital stay might increase, and mortality, 1 month mortality is 16%, 6 month mortality is 26%, and one or two symptoms might persist even after 6 months. So prognosis a little bit guarded, talking to relatives always helps. What can you do in outpatient care? Patient will remember कि delirium में क्या हुआ था, मैंने क्या किया था. तो educate the patient, educate the family members कि future में risk हो सकता है इसका. Give the patient at least 6 to 8 weeks for full recovery, and some cognitive effects might not resolve. So we can't tell the patient कि 100% improvement होगा. उतना थोड़ा बहुत समझाना बहुत जरूरी है. Okay? So with this, I end this lecture. If any questions you want to ask, the questions are welcome.